Hello students. Today again we are here to discuss another topic known as the spinal canal stenosis, and it is most commonly seen in the lumbar area. So today we are going to discuss about lumbar canal stenosis. Yes, it is also seen in the cervical region, but most commonly it is seen in the lumbar canal or the lumbar area. So let us see what is the lumbar canal stenosis. Here I have just given a picture to you people to get a rough idea about what a normal spinal canal looks like and how the stenosed canal looks like. And you can see in the stenosed canal there is narrowing of the spinal canal, and the neurological structures are being impinged, the cord, the nerve roots, and the degenerative changes and the bone spurs come and compress it. So this is the normal, and the difference between the normal and the stenosed canal. Another picture you can see here, the differentiate between the normal spinal canal and the spinal canal stenosis. Same here, you can see out of degeneration or any other cause. Here the disc is herniating down inside the spinal canal, and the canal space is narrowed down. Ultimately the structures are impinged. Here also you can see this is the narrowing of the spinal canal. Also we can see the narrowing of the intervertebral foramina. Here it is also narrowed and the nerve roots are impinged. So this is a rough picture that you can see how it looks like. And the causes, actually what we are going to discuss, the number of causes, like it is usually occurs in a person who is like ages, and the discs become drier or the discs shrink, and arthritis of the spine takes place usually in the middle-aged or the elderly people. Also it is seen in bone diseases such as Paget's disease of the bone and achondroplasia, defects of growth in the spine from birth, that we call it as a congenital defect, herniated discs which has happened in the past, injury that causes pressure on the nerve roots on the spinal cord, or the tumors, any kind of pathological condition, tumors present there and compressing the cord. Then let us see the definition. Stenosis means actually constriction or narrowing of a tubular structure. So when the spinal canal stenosis is actually defined as an abnormal narrowing of osteoligamentous vertebral canal and or the intervertebral foramina, causing direct compression or compromise of the dural sac, caudal nerve root or their vasculature, producing symptom of radiculopathy or claudication. If we see the history, it was reported long back in 1803 by a French anatomist, where he first reported the cord compression and paralysis in children severely deformed by rickets. 1891, Gowers considered the possibility of lateral stenosis. He noted that narrowing of the foramina may damage the nerve roots and radiating pains may be produced. 1910, Sumita described a narrow vertebral canal in achondroplastic dwarfs. 1920, Putty wrote about nerve root entrapment caused by degenerative changes in the facet joints. Verviest also had a major contribution. In 1949, he described narrow vertebral canal in patients without any disease or pathological condition in the classic sense. The narrowness was due to an isolated growth disturbance of the vertebral arch. So he coined the term developmental stenosis. 1954, he redescribed this clinical syndrome with his operative studies showing bony changes producing narrowed spinal canal, particularly in the sagittal plane. This is just to show you the posterior View of the lumbar vertebra L3, L4 assemble one motion segment. The spinous process, the superior inferior facet joints, the continuation here, that is the pars interarticularis, transverse processes, the body, the lamina. So this is some of the parts of the which you can see in the picture. Now if you see the canal, the anterior wall of the canal is the posterior surfaces of the lumbar vertebra. The anterior wall of the canal is formed by the posterior surfaces of the lumbar vertebra, the intervening discs, the posterior longitudinal ligament. Here, the anterior wall is not absolutely flat, so it has a slight transverse concavity. L5 is slightly convex. L4 exhibits an intermediate curvature. Now, the clinical anatomy, the posterior wall, the laminae of the vertebra. The posterior wall is composed of the laminae of the vertebra and the intervening ligamentum flavum. Lateral wall is composed of the pedicles of the lumbar vertebra. Between the pedicles, the lateral wall is deficient where the superior and inferior vertebral notches oppose one another to form the intervertebral foramina. So the intervertebral foramina is on the lateral side, and it is when the superior and inferior vertebral notches oppose one another to form the foramina. Posterior wall is composed of the lamina of the vertebra and the ligamentum flavum, and also we have seen the anterior wall. The Lee et al. Classified based on type of surgical decompression that there are three segments actually: retro discal segment, that is the entrance zone; parapedicular segment, mid zone; and the third segment is the exit zone. So this is the zones of the lateral canal. Now the entrance zone, the anterior wall is formed by the disc, posterior wall the facet joint, lateral wall pedicles, medial wall central canal. So stenosis can be caused by facet arthritis, vertebral body spurring, that is changes in the arthritic changes, and disc or annulus pathology. The parapedicular segment, that is the mid zone foraminal segment, it is the laterally it is surrounded by the medial border of the pedicle, anteriorly posterior vertebral body and disc, posteriorly pars interarticularis and intertransverse ligament, medially lateral recess. The contents are the dorsal root ganglion and the ventral roots, okay, where the nerve roots exit. So here the dura becomes confluent with the nerve root as epineurium, and stenosis is caused by the fracture of the pars interarticularis with proliferative fibrocartilage or lateral disc herniations, or sometimes spur from the undersurface of the pars interarticularis. The exit zone, the third segment, is an area lateral to the facet joint, contains the nerve roots, and stenosis is caused by far lateral disc protrusion or herniation, spondylolisthesis, hypertrophic facets with subluxation. These are the causes seen in the third segment exit zone. Now, what is the biomechanics actually? During flexion, the lamina of the two adjacent vertebrae moves apart, the interspace widens, producing lengthening and thinning of the ligamentum flavum. The posterior portions of the two adjacent vertebral bodies move apart, stretching the posterior portion of the annulus fibrosus. In extension, the ligamentum flavum shortens, becomes thicker, and buckles into the vertebral canal. The annulus fibrosus bulges posteriorly, decreasing the sagittal diameter. So it is very important, students. Just try to focus this point, the biomechanical point in extension. Why I am focusing this, you will come to know. In extension, see what happens. the ligamentum flavum shortens. It becomes thick and buckles into the vertebral canal. It buckles into the vertebral canal. Okay, focus this point. The annulus fibrosus bulges posteriorly, decreasing the sagittal diameter. So that means in extension, biomechanically, already there is an attempt of kind of narrowing of the spinal canal, whereas in flexion what you have seen is it always moves apart, it widens, it lengthens. So the ligamentum flavum becomes thin and it lengthens. Two vertebra, adjacent vertebra moves apart. Posterior portions of the vertebral bodies move apart, stretching the posterior portion of the annular fibrosus. So this is inflection. The space posteriorly or the spinal canal is relieved, or you can say anatomically, biomechanically, it is pulled apart and there is good space. But in extension, biomechanically, already there is crowding of the structures. So now this point you relate with the clinical sign, that is when there is a case of spinal canal stenosis. Because of this biomechanics, extension will be producing pain, or the symptoms will aggravate, or the extension will make the canal more narrower. Okay, understood? So extension, pain in extension or provocating, or the symptoms reproduced in extension is a positive sign of spinal canal stenosis patient. Based classification based on the anatomical area of the spine affected, we can see anatomical area, suppose cervical, it can be central or foraminal. Thoracic, it is rare. Central. Lumbar, as I said, most common. You can see the central narrowing, the lateral narrowing, that is the intervertebral foramina, or the extra foraminal, that is far out laterally more. And based on morphology, you can see that is absolute stenosis, that is the mid sagittal diameter of 10 millimeter or less, or a relative stenosis. Relative stenosis, that is based on morphology. Now, based on pathology, you can see one part type called congenital. As I have told you before, it may be spinal dyspharism, failure of vertebral segmentation, then Denquin syndrome, congenital forms of spondylolisthesis, scoliosis, kyphosis, developmental idiopathic regions like achondroplastic dwarfism, Morquio disease, that is the errors of bone growth. So these are some types seen in the congenital. If you see the degenerative and inflammatory, which is the other type, you can see a lot of conditions like osteoarthritis, degenerative conditions, inflammatory arthritis, diffuse idiopathic skeletal hyperostosis, scoliosis, kyphosis, degenerative forms of spondylolisthesis are all degenerative and inflammatory type. In a metabolic type, you can see some disease like Paget's disease, fluorosis, etc. Arnold et al. Classified based on pathological spinal processes like congenital, that is developmental stenosis, idiopathic or achondroplastic, idiopathic means unknown region, acquired stenosis. In acquired, he has included degenerative in first one, degenerative. L4, L5 level is the most commonly involved, followed by L5, S1, then L3, L4. The central portion of the spinal column is narrowed than the peripheral portion of the canal, like lateral issues of foraminal, or maybe there is combination of all the types that is combined, then spondylolisthetic or spondylolytic, which may include the lateral issues, foraminal and far out forms, iatrogenic, that is post surgical some kinds, post-traumatic late changes after a trauma secondary. Then miscellaneous like diseases like Paget's, fluorosis, fluorister disease. Now, what is the pathoanatomy? The stenosing pathology could be either of narrowing or encroaching in nature. Encroaching means kind of impingement. Narrowing means the canal space is narrowed. The narrowing pathology are mainly developmental. Encroaching are mainly degenerative. The encroaching pathologies could be static or dynamic. Now, if the encroaching is static, then anteriorly apparent lower marginal osteophytes from body, calcified annulus with or without nucleus,